Holly Cotton here, and I am super excited for our show today. So, first of all, it is September. If you were catching this show live, it is September, and September is Prostate Cancer Awareness Month. And what I wanted to do, because the whole point of prostate cancer awareness is to go get your prostate checked. So, what I wanted to do was actually give a little bit of information about that process because I know a lot of people are scared about it. Men, not women, excuse me. Let me clarify. A lot of men are concerned about the process. But what I really wanted to do is have someone come on that was an expert that could talk to us about life after cancer. After you get tested, after you get a diagnosis, after your treatment, that's always the scariest part is the unknown. So I'm super excited to have Dr. Paul Gittens come back on today. And if you guys go back to some of my earlier episodes, and he broke down a whole bunch of stuff for us before about sexual health, because Dr. Gittens is actually your practice is Rockwell Center for Sexual Medicine and Wellness, and he's going to tell us some more about what his specialty is and all of that stuff. So welcome, Dr. Gittens.
Thanks for having me again. I'm so excited to be here with you on the show once again. I've been watching you throughout the years, and like you've blossomed. You are fantastic and enjoy to watch.
Thank you. Thank you. Thank you. Okay, so just to start off, let's get people understanding of what your practice is, Dr. Gittens, because I know we're talking about sexual health, we're talking about, all of these other things. So people kind of don't know what that means because they're like, okay, so urology or what oncology, what are you doing? So give us the insight into what exactly your practice is.
So first and foremost, I'm a urologist, and so a urologist deals with like the reproductive system of men and women. After my urology training, I did a fellowship in sexual medicine, and sexual medicine is helping men and women who have dysfunction of any sort with problems. So for men, we'll treat guys that have erectile difficulties, guys that have problems with orgasms, guys that have low libido hormones. For women, we also treat them for pain with sex, menopausal issues, low libido, problems with orgasms. So just a gambit of things. Anything that can go wrong in the bedroom, we're going to treat you. And so that's what we do in my practice at Rockwell. We have practices here, and I have a practice here in Philadelphia, up in the Lehigh Valley, and the Poconos, if you know the Pennsylvania area, as well as in New York City. So that's kind of in a nutshell of what I do.
Okay, thank you for explaining that to us because again, it's a confusion on some people. I know a lot of people asked me before when I had you on before, they were like, "So," I was like, "No, he's not like a sex toy distributor. Like he's actually
Definitely not. Actually, a real MD, went to school for a long period of time and studied a lot to try to be able to help my patients and to really define my craft. So that's me, like I said, that's me in a nutshell.
Okay, well, thank you for that clarification. Now let's go into the first question, which is let's talk about prostates, okay? Because that, like I said, that's the whole thing. We want to talk about it. So most men know that they have a prostate,
Mhm.
and by some point in their life, they've had their prostate checked. If they haven't had it checked, can you give us a brief description of what it means to get your prostate checked? How does it work? Because I know I'm a woman, I don't have a prostate, but I've seen so many things on TV, the movies where, the men are like, "Oh Lord, I don't want to get it. Oh my God, I'm going to get invaded." Like it's always a
The
fear.
famous rectal exam. So if I could back up a little, I'm going to kind of talk about the prostate a little bit about where it is and what it does, and then we can kind of go into sort of the prostate cancer because I just think it's important to know for your audience to know exactly where it is because then we can kind of figure out why we should do that rectal exam. Okay. So I have a little model here. I brought this for you. This is just for you, Holly. So this is a model of kind of the reproductive system. So this is what it looks like on the outside. So you got your testicles, your penis there. And then if we split it in half, okay, if we're actually looking inside the body, we can see a couple of different organs. So this is going to be your rectum. Okay, this is where you have your bowel movements from. This here is your bladder. Look, don't forget we're looking on the inside. And this here is your prostate. So when you urinate, what has to happen is your bladder squeezes down, squeezes urine through the prostate, okay, into the urethra, and then it goes to the outside world. Okay, so there's two main things that when we talk about prostate, some of the difficulties that men have. One is going to be BPH, which is benign prostate hypertrophy. That means essentially it's a large gland, and the other one is prostate cancer. Okay, so those are the two main things that really kind of could wreak havoc on a male as he gets older in terms of the prostate. All right. So when you talk about prostate cancer, screening is really important because just like any screening test, the earlier we detect something, then the more likely it is to have a permanent cure, right? And so when you deal with prostate cancer, there's two things that we do to try to screen for prostate cancer. That's going to be one, it's going to be a PSA, which is just a blood test. It's a really easy blood test. Most people have had blood for a number of reasons, for cholesterol, for testosterone, at least in my clinic, but also for PSA. PSA stands for prostate specific antigen, and it's one of the things that we pick up in the blood that can detect prostate cancer. Okay. The other thing that we do for screening is a rectal exam. And as I mentioned before, the reason why we do the rectal exam is because the prostate is just right in the back of the rectum. So what we're doing is we're placing our finger in the rectum and we're just feeling that prostate. And what we're feeling for are like nodules or bumps or lumps that can indicate prostate cancer. The reason why we have to do both, and we'll talk about, I know there's some hesitation with guys in terms of doing a rectal exam, but the reason why we do both is because there's some prostate cancers that just don't emit a lot of PSA, right, which is the blood test. And one of the other indicators that we can use is the rectal exam, because sometimes we may feel the cancer, but we may not see it when we do blood tests.
So let me just ask you this, because I'm a nurse, but I've never done a digital prostate exam before. So what does it feel like? Because so you're going into the rectum. So how do you decipher? Because some people have hemorrhoids, like there's
Mm-hmm.
just nodules in the rectum, period. For you freaks that stick your finger in people's butts, like, I know it's a different sorry, Dr. Gittens, I'm just saying. So
I don't know.
how far are you sticking it in to actually get to like
Yeah.
where the prostate is, and how are you able to decipher? I mean, I know obviously you're an expert now, but
Yeah.
like, how was that process where you're like, okay, this is what tissue is, and now this is what a prostate is?
Yeah. So some of it is experience, obviously. Being a urologist, I must have done thousands of rectal exams. So some of it is experience. The other thing, in terms of how it feels, the like when you mentioned hemorrhoids are more towards the external portion, right? But what you want to do is, for me, I always want to make sure my guys are really comfortable. Okay, we place on gloves, we make sure we're using a lot of lubrication, and I let them know what's going on, and it's literally 2 seconds. It's a quick exam. There's no more than like the tip of my finger that's going in the rectum, and checking for any kind of prostate cancer or any abnormalities. So it's not as bad as most guys think. But just going back to if I just want to say that if guys are using that excuse not to get screened for prostate cancer, I would say then don't do a rectal exam. Get the PSA, right? The PSA is a lot more specific in terms of prostate cancer than the rectal exam. The rectal exam is used as just like it's used as an adjunct of what we say. So it's used in company with the PSA. All right. So if you're one of the guys that are saying, listen, there's no way that I'm going to get screened for prostate cancer because of the rectal exam, I'm here to say, well, just tell your doctor to get a PSA. All right. Even though we want to do both, but I'll take one or the other. Okay. I would take the PSA over the rectal exam for sure. But if I can do both, then I think I'm going to be able to pick up a lot more cancer doing both.
Okay, thank you for that clarification. Because, like I said, how much finger is going up, when, I know these are all the
Mhm.
questions that men have, because especially the ones that haven't gotten it before. Now, when are your recommendations? I know that we could all obviously go look this up by the, cancer American Cancer Society, but what are the general recommendations of how often a man should be getting a PSA or the rectal exam, and like what are the ages?
So there's guys that are low risk for prostate cancer, and there's guys that are higher risk for prostate cancer. So, for instance, men that are of African American descent, all right, Caribbean descent, they have a higher rate of prostate cancer. Men that may have a family member that has like a BRCA gene, which is one of the genes for breast cancer, all right, they're going to have a higher rate of prostate cancer, right? There's men that have multiple generations of prostate cancer, so they're going to have a higher risk of having prostate cancer. So for those guys, we recommend screening those men earlier. So we want to screen them between like 40 to 55. For me, as being an African American, I would want to be screened at the age of 40, right? Because one, I'm an African American, but I also have Caribbean descent, so that kind of puts me at a higher risk. And then I had a grandfather that passed away of prostate cancer. That puts me at a little bit higher risk. So it depends. So for guys that maybe Caucasian, maybe have no history of prostate cancer, um, men that, or even of Asian descent, they have a lower risk of prostate cancer, no history of breast cancer in the family. Those guys are going to be screened between 55 and like 69. That's the recommendation from the American Urological Association. So it really depends on who you are, where you live, like what's your genetic background, what your race is. We do know that people in North America have a higher rate of prostate cancer than, say, like Asia. And it's something in our environment as well, because if you have Asians that move to this country, right, and you compare prostate cancer rates from Asians in this country compared to Asians in Asia, the Asians in this country are going to have a lot higher rate of prostate cancer. So there is something about being in sort of this environment that's going to increase your rate of prostate cancer.
Right, because we have the worst. The I swear, America. Everyone thinks America is so great. Don't come for me. Don't come for me. But I'm just saying that whenever you're talking about all of the health factors that we have, it's just the obesity, all of the unhealthy diets, the all the environmental factors. Like there are so many risk factors here, and then you go to other countries and they're living to be over 150 years old with no problems. It's crazy. Now, let me ask you this, because if you have a risk, I'm just asking because I'm a breast cancer survivor, and so I didn't know that there was even a risk for me to have breast cancer. Honestly, I just was going on with my life. I thought I was fine and doing the
Mhm.
most, and I didn't have any risk. And I got diagnosed at 36. So, if you have a familial link or a history, can you request for like a PSA? Like I know insurances are kind of iffy about it, or the physician. So what if, my like you said, you have family members or you have a dad or an uncle or someone and they had it, like what should someone do to be an advocate for their health to get tested?
Well, I mean, I think having that discussion just exactly the way you presented it to your physician, right? And any reasonable physician is going to say, okay, I think that you are at a higher risk because maybe your mom had a BRCA gene, or because you're African American, or because multiple people in, multiple family members have had prostate cancer, or they had metastatic prostate cancer, which is when it spreads outside the prostate. I think any reasonable physician is going to say, okay, I'm going to order the PSA. And if they don't, you need to find somebody else. Or if your insurance doesn't cover it, most insurances should cover it, depending. If they don't, you can also go outside to an independent lab and get it done yourself. So there's a lot of different ways to get a PSA. You know, you have to be I always tell my patients, you've got to be an advocate for yourself, for your health. And so you can go out there and there's so many different ways. You can go on LabCorp, you can get it ordered, you can pay cash for it. It's not that expensive, but if there is a higher risk, I would say definitely get it done. And you want to make sure you keep that number, right? Because even if it's lower at 40, at 45, we want to see what that number is as well, because we also look at the increase in the PSA over time. So you want to make sure you're keeping that as a note. You're watching your PSA over time, because that could be an indication of prostate cancer as well, not just one number, but the rise in the PSA.
Got it. Got it. Okay. Now you mentioned two different things. You said the BPH and then prostate. So I know that BPH is very, very common, very common, especially in older men. I actually just sidebar. I was joking with a girlfriend, and she's not in the medical field, and she was talking about men or whatever, and I was like, listen, I'm not trying to date no older guy. I was like, I don't want to deal with their BPH. I don't want to. And she was like, what? And I fell out laughing, and I was like, I said, the fact that we just talk about it so commonly, like it's just like, whatever. But one of the things that a lot of men have is the BPH. And so I know that the way that you guys kind of start identifying that it something possibly could be going on is like the trickling when they urinate, the
Yep.
other issues. So give us a couple of the things to look for where maybe they're not in that age bracket yet, or maybe they got tested or they're not getting tested. Some of those identifying effects that where you're just like, hey, these are some things that are going on that might be BPH.
Yeah, yeah. So what BPH is essentially is, as I mentioned, that prostate, and that your urethra is going through the prostate. So as guys get older, for some guys, because probably genetic reasons, environmental reasons, just a number of things, nobody really knows exactly why, but the prostate starts to enlarge and starts to encroach or kind of squeeze on the urethra, right? So anything that's squeezing on their urethra is going to cause some kind of obstruction of some sort, right? And so when guys have symptoms, they're going to have sort of obstructive symptoms. That means that they may not be emptying fully when they urinate. So they may be getting up multiple times in the end of the night, right? They may be the guy at the urinal at the baseball game, and they're just waiting and waiting and waiting to go to the bathroom, and everybody else is like, you got two or three people that have already cycled through the urinals next to them. So the stream might be weak, all right? They may stop and start their stream. Those are like the biggest things. Sometimes if it gets really bad, guys can have some urinary tract infections, right? Because what's happening is that the bladder's not emptying fully, and then that urine in the bladder becomes like a pond, and because of a pond, you get some bacteria in there, and then you can get urinary tract infections. Those urinary tract infections can also lead to, and the stagnant urine can also lead to bladder stones, so they may pee like little stones out of their urethra. But in general, I would say the stopping and starting, getting up in the middle of the night, the hesitancy where you got kind of wait and then it'll go. Those are the biggest symptoms of BPH.
So I think that a lot of times men are afraid of the diagnosis and the treatment. So, what I wanted to do was really get some insight from you before we talk about the life after, because I think a lot of times people are like, oh, okay, I'm not worried about it or whatever. Because one, you don't want to get diagnosed. Maybe you do have the issues, like you said, you're standing up, and you think that that's just a part of aging.
Mm-hmm.
Is having a weak stream or whatever. So you're delaying going to get checked because you're like, so what are you going to do? What's the treatment? What's going to happen? So if my PSA is elevated, if I had a digital exam that showed that I had, like you said, the elevated numbers, maybe the last 2 years, my numbers keep elevating. You did a digital exam. You're like, I feel something that's not right. So I know a biopsy is going to come at some point. So
Yeah.
just give us like kind of how that timeline works of what happens after you pick up on those things that are like, hey, these are red flags. We need to pursue, further diagnostic testing.
Okay. So since we've been talking about two different things, I want to make sure we separate them when we're talking
Yes.
about like prostate cancer and BPH. So when we're talking about BPH, the symptoms that I mentioned, getting up in the middle of the night, weak stream, kind of hesitancy, dribbling after you kind of finish, those are BPH symptoms. Unfortunately, there's no real symptoms for prostate cancer, right? That's why we do screening, right? And so the guys with prostate cancer, they're not going to, they may, if they're older, they may have those BPH symptoms, but it's not because of the prostate cancer, it's because of the BPH. But if somebody just has prostate cancer, they're not going to have those symptoms, those urinary symptoms at all. So that's the first thing. And I want guys to understand that, because I don't want guys to think that if they're having some difficulty with urination that they're going to have prostate cancer, or it's a sign of prostate cancer. So prostate cancer is silent for the most part. And if we're not doing those screening tests, we're not going to find out. All right. So if we go into prostate cancer, as you mentioned, all right. So the PSA is up, or we felt something on the digital rectal exam. At that point, you're going to meet with your urologist, and they're going to do a biopsy. All right. So they're going to do a biopsy, and on the biopsy, they're going to look for cancer cells. All right. And if there's cancer cells, then we're going to have a discussion. All right. Just like so many other cancers that are out there, there's different grades of prostate cancer. There's ones that are low risk, right? And there's ones that are a little bit higher risk. And there's really high risk, right? Those are kind of the grading system of prostate cancer. So your treatment is going to depend on what type of prostate cancer you have, right? So if it's lower risk, right, you may say you're older, the treatment might be not even the treatment. We just may want to watch you over time. We may just want to watch your PSA. We don't want to do anything. We're going to watch the PSA. We may do another biopsy in another year or so to make sure it hasn't advanced. So that's one thing. That's called active surveillance, right? That means we're not doing anything. And the reason why we've kind of pivoted towards active surveillance is because we know that a lot of men that have prostate cancer, they don't die of prostate cancer, especially when they get older. They're dying more of cardiovascular disease, or they're dying because of stroke or some other things, right, as they get older. And the prostate cancer is not really going to cause them to have any major issues, right? The 5-year survival of prostate cancer it's almost like 90 something percent, right? Because it's a very, very slow growing cancer. This doesn't mean that you should wait to be diagnosed, but it's one of those things that if you are diagnosed, then we can watch you for a little bit if it's low grade, and we can just see how you do over time, right? Okay. So that's one type of treatment. Other treatments are surgery, there's hormonal therapy, there's radiation. So those are the other types of treatments, but it's going to depend on the grade or the aggressiveness of the prostate cancer. All right.
Wow. Okay. The monitoring one just kind of messed me up there, because it's like you every other cancer, not every, okay, excuse me, that's a broad statement, let me not say that.
Mhm.
Most other cancers, when you get a cancer diagnosis, it's I want this cancer out of me, how can I treat it, what am I going to do? And you also didn't mention like chemotherapy as being like a typical treatment, whereas a lot of the other cancers, the first thing they want to do is put you on chemotherapy before
Yeah.
anything.
Like prostate cancer is a little different when it comes to that. You know, it's more radiation sensitive. It can be helped with surgery, where chemotherapy is sort of the latter of the treatments. You know, so we don't that's not the first line treatment for prostate cancer. But yeah, so this active surveillance or watchful waiting has sort of come along and within the last 10 years, because what we were treating some of that low grade prostate cancer. We're a little too aggressive in treating it, so we kind of scaled back because, like I said before, a lot of guys are more likely to die, especially if they're older, of some of these other things that are more common, like cardiovascular, like having a heart attack, than their prostate cancer. So it depends. Watchful waiting or active surveillance isn't a treatment for everyone, but it is a treatment for some guys that have low grade prostate cancer that aren't interested in treatment. Because treatment does, when you have treatment such as radiation and surgery, you are going to have some side effects, right? And so because of those side effects, guys are like, well, I want to just wait a little bit, right? Um, and see to see if my prostate cancer progresses.
Okay, got it. Thank you, Dr. Gittens, for that detailed explanation, because I didn't even know all of that. I mean, I know that's not my expertise. It's not my forte. I know people who have prostate cancer. Obviously, I'm in a cancer community, so I always meet people that have prostate cancer. But I know also I have a friend, and oh my God, this is his third go round. Like he's had prostate cancer like I guess it was super aggressive. He had some kind of treatment done, and he's in his late 60s now. And then he got into like an experimental trial and some other
Mhm.
stuff. And anyway,
Yeah.
so poor thing. This is like his third time that he's like going through this whole process. Okay, so let's do worst case scenario. Okay, worst case scenario, I have a very aggressive prostate cancer, and I need surgery and radiation. Okay,
Okay.
so that's just give us a visual of it, because I know like breast radiation, it's on the breast. So if I'm doing radiation for prostate cancer, how are they getting the radiation to my prostate? Because the prostate is the internal organ. Are they going like
Yeah.
over the testes? Or are they going from the rectal
No, they
area?
go from yeah, they go right, essentially right above the pubic bone,
Okay.
and the radiation beams are kind of directed towards that area because the prostate, as you mentioned, is kind of way down in the pelvis. If you remember
I was
my
about to say,
lovely,
get
my
this
lovely,
thing.
my lovely graphic. Let me tell you, I searched high and low for this thing for you. Okay,
I love
so
it. I love it because I'm a visual person. So I'm like, let me see what it is. What is that?
that's right. So we're coming in kind of this way into the prostate. That's kind of where the beams are going. So obviously, with that, we've gotten a lot better with radiation. But when I was a resident a long time ago, that radiation would affect the rectum, right? Because don't forget the rectum's here, so you can have some rectal issues. It also affected the bladder in a lot of guys, and they would have some blood in their urine that sometimes we needed to have surgery to correct. So that's how radiation is done, and surgery is kind of done similar, where you're kind of going in this area here, right, and then you're making an incision here, making an incision here, you're removing the prostate, and then what we do is we sew the urethra to the bladder, right, so there's no prostate in between.
Hmm. It's very invasive.
Pretty interesting.
It's very
Pretty
interesting.
interesting.
I
And then
remember.
there's also hormonal therapy as well. So, one of the probably one of the first treatments, the first major treatment of prostate cancer was castration. So what they used to do is they would remove the testicles of guys because prostate cancer, at least initially, is hormone sensitive, and so they would remove the testicles, and that would have the prostate cancer regress. But oftentimes, it would always come back. That we don't do that anymore for the most part, and at least not in this country for the most part. We use medications to reduce testosterone.
Okay. All right. So that's worst case scenario, just for anyone. Like, what's the worst of the worst of the worst that can happen? So that's like
But the
the
best of the best of the best is that you get screened, you have a low grade prostate cancer. They're watching you if anything, or they do a surgery and a radiation, and that's it. That's the best case scenario. And I think that happens a lot more. That definitely happens a lot more than the worst of the worst of the worst. So I don't want anybody to be nervous about, getting screened, and finding they have a diagnosis of prostate cancer. It's something that thousands of men find out every year, right? And I would say that, like I said, that 5 year survival is really, really high. So it's not something to avoid because the longer you wait, then the harder it is to treat, right? So, all the guys out there, or even, the ladies who have guys, they should, be pushing their men to get to screening and to see if they have any prostate cancer.
and see, that's what we do, Dr. Gittens. See that we
That's what we
educate
do.
people. We
That, that's
we push.
that's
We
what we
like, hey,
do.
this the worst of the worst, but look, this really ain't probably gonna happen to you, but this could be you right here. So go get
That's
tested.
right.
Okay, so now let's get to your specialty, because now we're talking about you got diagnosed, you had radiation, or you have this, or you're going through this. So I know as a man, if I had a diagnosis of prostate cancer, and for me, it would constantly be in my head to have a sex life. Like, can I still, now that I got this test, what comes after it? Because I think a lot of the times people like to be oblivious about things, because if I don't know about it, then it's not going to affect my life in a negative way. So do you have people that come to you and they're like, listen, I have prostate cancer, this is what's going on, but I don't know, maybe mentally I can't get an erection, or what goes on after that diagnosis of cancer?
Yeah, so I see guys before they're treated, but oftentimes I see them after they're treated. And you know how we always keep it real, right? We got to keep it real, and so we do know that those treatments of prostate cancer can cause a couple of issues, right? It can cause some urinary incontinence because don't forget that bladder is right there, and if we're removing the prostate, then the prostate also helps to kind of keep the bladder from leaking, right? Um, but also erectile dysfunction because our nerves for I'm going to use this I'm using this again. Look at
I
this,
love,
right?
hey, bring the penis out. Bring it out.
So our nerves that are going to the penis are actually going around the prostate as well, right? You got to think of this like in a three-dimensional kind of model. And so when we do radiation or surgery, then we can have some compromise of erectile function, right? And so that's where I spend a lot of time with my guys in terms of trying to get them their sexual function back. And so we work with them before. So we give them some tools what to do before they have their therapy, but then afterwards as well, we're really working on kind of rehabbing the penis, trying to get things so they can have some function afterwards. So I spent a lot of time doing that and a lot of counseling in terms of what we should be doing. All right.
So, whenever you're talking about a loss of function, let's just be specific about some of what loss of function is. So, loss of function, when you're talking about it, means that they can't get an erection or they can't climax. What does loss of function mean?
Yeah. So anybody that has surgery, right, after for prostate cancer, they're not going to have an ejaculate, right? That means that they're not going to be able to ejaculate. You know, there's other words for that, but for ejaculation, they can still have an orgasm because the ejaculation and the orgasm, even though we think of it as one kind of synchronous event, it's actually they're separated, right? So guys can have a great orgasm. I even have guys that say that their orgasm after prostate cancer is better than their orgasm, you know, after prostate cancer treatment or surgery is better than what they had before. All right, not to say that's for everyone, but some of the guys will say that. But you won't see that fluid come out. The fluid won't come out if you had surgery. All right, so that orgasm is the same in terms of the emotional and the intensity, but the fluid won't come out. The in terms of I forgot what the conversation. What was I talking about? I'm going all different
No, no,
tangents.
no. I was saying, like, what are some, like, whenever you're saying, like it being dysfunctional,
Oh, dysfunction.
like
Okay, yeah. And so for the erections, so you can have a degree of dysfunction. It could be some problems with just maintaining the erection or starting the erection. Where you know I always give guys a scale in my office, and you know my scale is like 0, no erections, 5, you could stuff it in, 10's a great erection, right? So some guys might start at like a 9 or a 10, and they may go to like maybe a 6 or a 7 or a 5, or even a 3 or a 2. It just depends. We do know that there's some risk factors, right, that will predispose guys to having more likelihood of having erectile difficulties, right? So if you're over the age of like 50 to 55, right, you're more likely to have some erecting problems as opposed to a guy that's like 40 years old. And if you go into having surgery or therapy and you already have some difficulties, most likely you're going to have more difficulties afterwards. So those are like the two big factors that we always think about prior to therapy. All right. So that range could be from not having an erection at all to having just a less quality erection when it comes to prostate cancer. And I think this is something that guys should know because they can start getting ahead of it, right? Because what happens is, you know, this is kind of how the conversation goes. You know, after the diagnosis of prostate cancer, the doctor says you have cancer. And even though he may talk to you about some incontinence issues or rectal difficulties, you're not listening, right? Because all you're thinking about
cancer.
is I'm gonna die, right?
Right.
I just got cancer, I'm gonna die. I don't hear anything else, right? So you know, it's something that guys should know because it's something that we need to work on either before or we're going to work on it during the process. So at the end of the day, our erectile function is better quality than it would have been if you didn't do anything, right? And so that's where I come in and I help guys um, try to get their erections back or to try to preserve their erections for after prostate cancer therapy.
Let me just ask you this, and this is just kind of a sidebar of what you were just saying. So I know, like you said, your training was as a urologist, like but
Mhm.
then you transitioned because you were like, I want to specialize in sexual health. So for me, I would think that being in what you're doing right now, I I picture that you do so much counseling and mental health mental health check-ins because there's something about well, obviously you're a man, Dr. Gittens. I don't know, so I'm not going to be like some about
I'm a
men
man.
and them penises. Like,
That's right.
so for a man, because for whatever reason, like men, I am man, I
Yeah.
gotta pound it
And
out. I
we're connected to our penises in so many different ways, emotionally, our confidence, everything,
So how do you like what are some of the things that you have learned to sort of engage and talk about to these men to say and like how I just want to know your the training that you had to put yourself through because it's not like you just going in here and making a cake like you're having to explain every step of the process then the cake doesn't turn out right now they're crying about that now you have to console them. I'm sure you probably have a partner or a spouse, they're in there, they're upset that the husband can't perform or whatever. So give us just like a little snip of like that process for you and some of the things that you have to sort of counsel people on when they're going through this loss of, like you said, the dysfunction.
Yeah, after urology training, I did a fellowship, which is special training in sexual medicine, and they don't really prepare you for exactly what you're saying, right? It's more of a regimented kind of thing where you go in and you learn all about whatever it is, if it's testosterone, if it's orgasm, if it's all these other things, you learn how to treat it medically. But they don't really prepare you how to treat the personal side of it, right? And what I find as a physician is you got to listen, like, because everyone's story is so different, right? There's guys that are out there that they may be married, or they may have a partner, or they may have maybe they're single and they're going out in the dating world, right? Or maybe their spouse or their partner is kind of angry because they have erectile difficulties, so the key is really listening and trying to figure out and trying to be able to kind of bond with your patient. I mean, hopefully I come off as compassionate, but I'm also listening for certain things that I can kind of bring up and certain things that we can do to kind of help with their sexual function. But everyone is so different. I've treated thousands of guys with these problems, and I would say that no one is exactly the same, right? There's always different scenarios. Sometimes there's cultural issues. Sometimes, as I mentioned, there's spousal issues. There's guys that will sit on the couch and watch the ball game all night, so they don't have to go into the bedroom because they're embarrassed about their erectile function. So there's so many things. And when you look at erectile dysfunction or erectile difficulties, which I like to call it, and even if you look at productivity at work, right? We know that guys that have ED have higher rates of depression. They don't show up for work. Their confidence is a lot lower. It's just, and when you look at ED, even taking prostate cancer out of it, and you look at the depression scales, it's just like having cancer for a lot of guys. All right. This is outside of prostate. These are just guys that have just, ED without having cancer. So it's a depressive state, and it's something that I think that you got to listen to, because people, they know, they know they're having problems. Sometimes they want to talk to you about their problems. They want somebody that's going to listen to them and take them seriously. And so that's what we do. We do a lot of that here. But then we get down to business. We got to get down to business, and we got to make sure that these guys are doing better than when they came in, right? And so you got to make sure you do a meticulous workup. We do ultrasounds in everybody. We have advanced treatments in terms of what we do. We have exercises to do. We have a whole program for guys that had prostate cancer, or guys that are just coming in and they just have ED for other reasons like diabetes or hypertension or any of these other reasons why guys get it.
Right. Well, I could tell you because I know just from me like I remember being a green nurse, like just getting out of nursing school, and I'm going in and I'm all task oriented. Okay, so let me do this blood pressure, let me do
Mhm.
this, and like let me get here's your 4 medications. I don't know. Okay, these are the side effects.
You
Like
mean business. You
you're
mean
so
business. Yep.
yeah, and
Yeah,
then
of course.
all they want to do is like talk or cry or do this, and I'm like, oh
Yeah.
my god, this is not. I'm
Medicine, I agree. I think medicine is kind of like remember when you first got your license, right? And you're driving and you're just paying attention to the road, right? It's kind of like what you were doing. You're like you're focused, you're focused. And then at some point, and as a nurse and as a physician, you start looking around, right? And you get more comfortable because you know the road. You kind of got your sense on the road, but now it's time to kind of really feel and like see what else is out there. And that's kind of the experience that you probably had, and that's experience is as training, like, as a urologist, you're like boom, boom, boom. But then you start looking outside and you start talking to people, and it's an emotional thing. And you gotta really be in it with your patients. That's the key. You gotta be in it. You gotta be invested. You gotta know that they have to feel, and I hope everybody that comes to my practice, they feel like they're the only person in the world and we're talking and it's just us. Right. And we're gonna try to solve this together.
Well, I can tell you have a big heart. I love that. And but yeah, cuz I also, so now I teach nursing, and that's one of the things that I tell the nurses or the CNA students. I'm like, "Listen, let me let you in cuz no one told me this, but if you don't have a heart, if like it is not task oriented. You might go in a room, you might be in there for 30 minutes just listening to them talking about."
Yeah.
And it's like,
Yeah.
ma'am, I got 10 other people to go see. But yeah, if your
Mhm.
heart's not in it, that's not the right way. Okay, so the last question I want to ask, because anytime we identify the problem, we talked about treatment, we did all of this, but I want to ask you about risk factors and things to do to maybe reduce, if there's anything that like what are some of those things that we can reduce our chances of getting, even though we talked about cancer today, but we also talked
Mhm.
a little bit about BPH. I know there's other things, but what are some things that you teach your male patients, like, hey, you need to stop doing this, you need to do this, you need to do this, because this is what's going on.
Okay. So these are just recommendations, and the recommendations I would always give are kind of recommendations for most cancers, right? So smoking, we know smoking is a big deal, right, when it comes to cancers, right? We know that guys that exercise are probably going to do a little bit better. Saturated fats, those fatty foods like the bacons, the sausages, the cakes, all those things can probably induce some cancer. It's not specifically for prostate cancer, but just for cancer in general. We know that guys that have like insulin resistance is this whole new field with guys that have like pre-diabetes, right? And the insulin we feel can feed some of those cancer cells, right? And so the idea is to lower that glucose, lower that insulin. And the best way to do that is to exercise and losing weight. Those are some big things that I always recommend for prostate cancer or for any cancer. When you look at those things specifically for prostate cancer, there's nothing that that is a strong indicator of lowering the risk. But those are things in general that people should do to try to lower the risk of general cancer, and hopefully we can catch that prostate cancer in that batch to lower that risk. Does that make sense?
Right. So basically, y'all need to stop going to Popeyes on Tuesday getting your Popeye special.
Lose the weight, exercise, you know, um, those are just, and the cigarettes. Cigarettes are big, like
What about
smoking is
vaping?
out.
Because everyone's doing vaping instead of smoking, and they think that there's no
Yeah.
risk. So even vaping.
Yeah, so we don't know the risks in terms of cancer yet for vaping. It's all coming out because vaping has only been around for like big popular for the last like 5 or so years. But I would imagine that we're probably going to see something, but we don't have that data yet, so I can't say that it's a positive or a negative. But I would imagine it's probably going to be a negative, but I don't
Because
know.
it's the nicotine.
Yeah, it's a lot of things. It's the constituents within that vape.
Mm-mm.
So we don't know. I can't say
I
100%. I'm not
know,
going to
I
go.
know, I know, but I keep telling people just to be, cautious with that, because, I mean, if you, I don't, let me just sidebar real quick. If you were with somebody that vapes, I mean, they're like every 2 minutes. And I and I'm like, how many times you gotta hit the vape? Like, gee
Yeah.
whiz.
Imagine the days before that, they'd be smoking the cigarettes and everything before that.
Right, right. Anyway, all right, we're
But
gonna come back and fuss at y'all about vaping. But anyway, thank you so much, Dr. Gittens. I really appreciate one. I'm in awe of your knowledge and just how you are able to share that information in a very tangible way. I love that. I love talking to you. And also, for anyone that is looking to get in touch with you, reach you, seek out your services, go ahead. And I want to just let y'all know, since the first time Dr. Gittens came on, his Instagram them blew up. He got some.
not like yours, not like yours. I'm working on it. I'm
Well,
working on it.
if you post a picture in a bikini, I promise you'll get some followers. But
Uh,
but he's got a YouTube. He's got all kind of stuff he's doing. He has a lot of educational videos. He talks about these things in his content. So, he also has some of this research and this education that's also accessible for you, if even if you don't live or you're not going to his clinics or whatever. So, Dr. Gittens, tell everyone your clinic information, social media handles, website, all of that great stuff.
yeah, so you can find me at Dr. Gittens. Once again, it's a work in progress. I love coming on the show because one, it's always wonderful talking to you, but you always give me hints on and tips on what to do with my Instagram and everything. The website is Rockwell Centers with an S .com. And my practices are in New York, here in Philadelphia, and in the Lehigh Valley, and hopefully we'll be expanding even outside this range. And I love being on the show. I love speaking with you. You're just going like this, which is just great. And I think you're fantastic. And just keep doing all the education that you're doing. We need you out there.
Oh, thank you. Thank you. You hear that, Oprah Winfrey? I love it. I love it. And so I will also have all of Dr. Gittens stuff for you people that are driving or on the treadmill when you're listening to my show. Look in the podcast notes. It'll be there will be clickable links, information. I'll have the social media handles, all of that stuff as well. So again, the whole goal of today is education. We want to make sure that you're aware of prostate cancer, but not only that, but the treatment options, the chance of survival. Like, we just wanted that you can have a normal sex life. We just wanted to just explain the other part of it, the life after, of not just, hey, go get checked, go get checked, go get checked. The importance of getting checked, what happens when you get checked, what happens after you get checked, and also having sex and some type of sex life after all of that if you are diagnosed. So thank you again, Dr. Gittens.
Thanks for having me.